Hello, friends and colleagues. It's a pleasure to meet everyone in this webinar. And I would like to thank the organizing committee for giving me this opportunity to share my experience in establishing two distinct laparoscopic liver resection program, laparoscopic living donor program, one in Korea and one in the United States. Here, I'll start with sharing my screen. So the topic I was given today was how to best set up and train, and are you ready for laparoscopic donor hepatectomy? I'm currently the head of HPV surgery and director of laparoscopic liver surgery at Cleveland Clinic, Cleveland, Ohio, in the United States. These are my conflict of interest. So this goes back a decade ago when I first started my laparoscopic liver program back at Samsung in 2008. I had trouble moving on to major hepatectomy, even despite 4 years of extensive experience in laparoscopic liver. And when I had a revelation at the end of 2011, and then after that, the program grew into very heavy major resection. And just about a year and a half after that, I was able to start our laparoscopic living donor program, which became one of the largest laparoscopic living donor program in the world. I'm so happy that after I left the Samsung Medical Center, that two of my very talented junior surgeons, Professor Choi and Professor Kim, were able to take on the program and take it to a different level. Now it's a program that does more than 400 lap liver resections a year, being the largest laparoscopic liver program in Korea. They also do over 110 lap living donors a year. 100% of all donors are done laparoscopically, and they just recently published a cumulative experience of lap donor cases of above 500 of a single center institution, including my early experiences back at Samsung Medical Center. After I moved to the United States, the picture was very similar. Cleveland Clinic had started lap liver program back in 2006. However, for over a decade, they were struggling moving on to a major hepatectomy. After I joined here, shown in blue arrow, a lot of things were changed. And just about a year and a half after I changed the system, we were able to start a laparoscopic living donor program. So what is the secret formula into that I was able to establish the two different programs? I think there are two distinct learning curves in any very complex, minimally invasive program, especially. There is one learning curve that only reflects the learning curve of the surgeon. There is a lot of learning curve to do to perform a major hepatectomy, but we often forget to talk about the system in which we are included, and we forget about talking about the whole team. And therefore, that's going to be the topic I'm going to be talking about today. So it's all about building the system, instruments, setup in the OR, and the team. Now, the instruments, it is a very expensive program. I routinely use a 3D screen. This has been something that I had in mind since 2011. I also use routinely ICG technology. Ultrasonic probe, ultrasonic shear. After I came to the United States, Aquamantis has become a routine instruments that I use. AirSeal is also a routine that I use. Bipolar is one of my favorite instruments. Suction irrigation, and of course, my dear friend Kusa cannot be left behind. Now, why 3D? I think the brain has a finite energy resource in a given period of time. And I think it's very important to save brain energy. Don't spend it in trying to coordinate a 2D screen to a 3D motion. Save those energy to do more critical thinking. And through this saving up brain energy, I think you can shorten your learning curve. You can be a much faster learner. And also this will result in a safer operation. It's important to standardize your OR setup. You can see here on the left side how many lines we use during this complex laparoscopic living donor. And you don't want to have a situation where you're all tangled with lines when you want to do a procedure. And therefore, it's very important to have a standardized way of setting up things so that these things don't get tangled. So the way I usually do is going back to this picture. On my left-hand side, I always have my bipolar, my suction, my ultrasound as here, you've shown here. On my right hand, I always have the camera probe is always on the right because the camera scope is also always on my right, but the Acomantis and some instruments are always on the right side. And the Kusa is always on behind me on a separate Mayo table. And with this way, I can sort of like compartmentalize the lines of the ones that I use for bipolar versus the ones that I use, let's say, for the Acomantis. And it's very important to have this compartment, separate compartments. And this can be of your preference. Just make sure that you don't get tangled when you do the operation. Now, another thing that we always do is this 3D vascular biliary reconstruction. In every case that we do living donor, this is from a company called Mevis. And here you can see a picture of the OR. I often have visitors coming and observe. And on the right-hand side, the screen of the right-hand side is, you can see that I've put the Mevis on. And here I'm discussing with my dear colleague, Dr. Asejo, about where to cut the bile duct. And you can see that, you know, by this, having this 3D reconstruction picture right on your right side while dividing the bile duct actually improves the outcome and the safety of the operation quite a bit. Now, building a team, of course, we all know that it's important to have a good team. When I first came, I took time to dedicate some scrub nurses, some smart and good scrub nurses, and did my due diligence to train them properly, how to assist me properly. Also with the anesthesia, because the environment of laparoscopic liver resection is a little bit different than the environment of open liver resection. I have had separate discussions with them multiple times on the importance of low volume anesthesia, the importance of intra-abdominal pressure, and with the results of anesthesia. And now we have a very good team collaboration with our anesthesiologists. We get along really well. One thing I think I would like to suggest for those centers that are able to have a dedicated scopist or surgical assistant to have one, because having a dedicated scopist will improve the quality of the surgery tremendously, taking a lot of weight on your shoulders off, because you don't have to be continuously struggling trying to get the correct vision during the procedure. Once you're ready, take it step by step. You don't want to go jump into the double black diamond the day you learn how to ski. So it's important that you accommodate your team, your whole system, make sure that that system is running properly, in a green area, the blue area, and then move on to the black diamond. So looking at the annual cases of that I had at Cleveland Clinic, you can see before I joined, it was they had less than 10% of major hepatectomy. And you can see here in red, they had a very large proportion of conversion. After the system was set up, 2018 was the time when the system was trying to get mature. And by the time it got mature, you can see that over 50% of all liver resections done at Cleveland Clinic are done for major hepatectomy. And also you can see that the conversion rate, once the program was fully mature, was very minimal. And this is, I'm really proud of all of my colleagues that have been a part of this whole project. Look where we are in the United States as respect of living donor and minimum invasive. This is a data collected by one of my colleagues in San Antonio. We have not the numbers that there are in Korea, but we have made quite a bit of progress. The numbers are ticking up. We have more laparoscopic versus robotic, but I think this will change very soon. We also have more right and left compared to left lateral, which has around 20% of the whole program. The first case was done in August 2019. It was initially intended to do it by lab assisted because I just wanted to make sure that my team was fully ready. Apparently, everything went so well that it ended up being the first laparoscopic living donor case. Estimated blood loss was very minimal, and the patient was discharged at day 5 without any complication. And when looking at the whole picture, you can see here the program was a program that used to do around 14 cases a year, and that grew into a 33 cases a year, being one of the largest programs in the United States. Cumulatively, we did more than 78, and we did 78 cases here. And you can see that it's a more heavily left-dependent program compared to right. And since November, 3 months after inception of this laparoscopic program, all donors currently are done laparoscopically, and we have 0 conversion rate. I love this graph, is the change of operative time. You can see until case 30, the time that it took to do a lab living donor was gradually decreasing. But after that, it increased. It's not because I became a bad surgeon. It's because I started having my colleagues do part of the operation, either 1/4, 1/3. Either they do the mobilization, either they do the parenchyma transection part, the highlight dissection, or the extraction of the graft. I slowly started having them involved on part of the operation. And with that, the time was increased. But now we are back to around 6 hours, and they're still doing close to half of the operation. And I think this is very important when you want to have a fully mature program and with surgeons that are able to carry on doing this program without your presence. Just comparing to open versus lab, as I said, we shifted from a right-dependent program to a left-dependent program, which is out of this topic of today, but hopefully I'll have a chance to talk about it in the future. The operative time, interestingly, was reduced after we started a laparoscopic program. And of course, the estimated blood loss, overall complication rate, and the length of stay was reduced after the laparoscopic program. Comparing the left versus right, you can see that the right hepatectomy had more female compared to left in more males, which makes sense because males are bigger. But interestingly, the operative time was not different, nor was the estimated blood loss and the length of stay. Looking at the complication compared to open, we're able to reduce more than 2.6 times of overall complication. And we just looking at the major complication rate, we're able to reduce it close to 3 times as compared to open surgery. And therefore, it is a very, very safe operation. This is one of my last slides, and I love to share this story. And this is a program that it was an experience that I had with one of my dear colleague, Martin Ditt from Chile, who was trying to develop a laparoscopic living donor program. And with a lot of sharing, here you can see a lap full left today using many of your tricks, your trocars, your ICG protocol, telecoaching, clap, clap, clap. So even though he had relatively not the experience that I had, I was able to communicate with him, trying to communicate how to do major hepatectomy. And you can see here, a couple of days later, they sent me another video of lap right, and soon he was sending me a video of his first successful laparoscopic right donor hepatectomy. So I think as long as you learn how to set up the system and you have good proctor, this is something that can be done. So take home message, build a system, don't complain about it, get the instruments ready, get the OR system ready, build a team, and take it step by step from minor, major to donor, and get a good proctor. The lab donor will never be easy. It doesn't get easier, but you just get better. Thanks so much for your kind attention.